Welcome everyone to this webinar on digital platforms. My name is Megan Bishop and I'm the team leader for the WISH4Results project. And we're co-hosting today's webinar with the IBP Task Team on family planning and reproductive health and COVID-19. So I'll just start with some logistics. First, I want to let everyone know that the webinar is being recorded and will be made available for others to view and listen after this. I also want you all to know that French translation is available. If you'd like to listen in French, please click the globe icon at the bottom of your Zoom screen and select French. And finally, throughout this webinar, please make good use of the chat function in Zoom to share your thoughts and questions, which we'll come to during the discussion portion of the webinar. We've reserved a good chunk of time, so we'll get to all of your questions and comments there. So please do feel free to submit any questions you have as they arise. So I mentioned I'm the team leader for WISH4Results, and for those of you who don't know about us, we're the third-party monitor for the FCDO-funded Global Women's Integrated Sexual Health Project, which is known as WISH. And this focuses on reaching women, particularly the vulnerable and underserved, with family planning and reproductive health services. In line with today's topic, WISH4Results and our WISH partners, MSI Reproductive Choices and the International Planned Parenthood Federation, have just released a learning brief focusing on how SRH organizations have adapted their digital approaches to the COVID-19 pandemic. You'll be hearing more from our panelists today about some of the experiences highlighted in that brief, and I encourage you to read the learning brief and the other 3 learning briefs in our series that focus on SRH program adaptations to COVID-19. And my colleague Pippa will pop the link to those briefs in the chat for your easy access. We wanted to focus today's webinar on digital platforms because these have become such integral tools in health service information and provision during the pandemic. And while certainly the use of digital technology in health has been on the rise over the last decade and more, the pandemic has brought about an acceleration of this, including the development of new technologies and platforms and the adaptation of existing ones. Digital health technology is being used to address both supply and demand side challenges in family planning and reproductive health. And that's anything from training and supporting health providers to promoting health services to providing clients with information, counseling, and links to in-person services. So if you want to pop up the agenda slide, I'll just mention what we'll be exploring in today's webinar. So the key questions that we'll be going through are: how and why did digital adaptations to family planning and reproductive health come about during COVID-19? And how are we adapting emerging evidence for future guidance? Who has benefited from accelerated use of digital interventions? Who hasn't? And how are we protecting users? What are the consequences of the unintended digital revolution? What will we keep and what will we let go? So to explore these questions, I'm delighted to introduce you now to our panelists. Our first presentation will be from Tigist Tamrat, a technical officer at the World Health Organization, who will be summarizing current guidance on the use of digital platforms in sexual reproductive health and rights. We'll then hear from Rachel Misra, the Senior Marketing Advisor for Digital and mHealth at MSI Reproductive Choices. And she'll be discussing MSI's experience using different digital platforms and examine the question of equitable reach. After that, we'll hear from Katira Abdi Wahab Ahmed, the WISH Technical Officer at the Sudan Family Planning Association. And she'll be sharing their experience of a digital call center that was implemented during the pandemic. And finally, we'll hear from Millie Kagwa, the Senior Clinical Advisor at PSI, to talk about PSI's experience with digital technologies during the pandemic. Before I turn this over to our first panelist, we have a couple of questions we'd like you, the audience, to answer. So you'll shortly see a poll displaying on your screen. the questions we'd like you to take a moment to consider and respond to are: how have you used digital technology to support the maintenance of family planning and reproductive health programs during the COVID-19 pandemic? And which digital platforms have you leveraged the most during the pandemic? So I'll give everyone a few moments just to respond to these polls. I see we're having a little bit of technical difficulty with the polls. The first one, I think, is multiple choice. The second one is one response only. Great, I'm starting to see some results come in. So really interesting results. Looks like for the first one, people are using information provision to clients as one of the main ways they're using digital technology. And in the second question, social media platforms are being leveraged the most. Thanks to everyone for participating in these, and we'll pick up again on this during the discussion section. So I'll now turn this over to our panelists with the reminder to please do make use of the chat function during the presentations. So first, let's hear from Tigust at WHO.
Good morning, good afternoon, everyone. And I'm pleased to be here alongside fellow panelists to really discuss the ways that digital technology has come to the fore during the COVID-19 pandemic in accelerating access to family planning services and just sexual and reproductive health services broadly. And really trying to see the ways in which technology has been harnessed for maintaining access to these essential services. I'll actually be speaking a little bit about some of the resources and guidance that was developed right prior to the start of the pandemic in 2019 in the development of the WHO Guideline on Digital Health Interventions, where we really try to see some of the salient ways in which digital technologies was being used for health system strengthening, for service delivery, and formulating recommendations through the rigorous guideline development process that WHO has. And so this guideline, the recommendations on digital health interventions strengthening, was released in April 2019. So this was a good year before things really, with COVID began happening. And it's available at the link provided below. But essentially, the objectives of this guideline at the time were to review the evidence supporting different digital health interventions. And at the time, digital technologies didn't have the same political will and the same level of uptake as it does now. I think really the COVID-19 and the pandemic has really forced all of us to embrace technology, not just in healthcare, but we've seen it also in work situation, schooling. And so pandemic, but also other things such as stock notification and commodity management, digital decision support tools for health workers as they're providing services, digital tracking, in terms of having a medical record that can be able to track longitudinally different clients. So this is something very particular to cases such as in pregnancy, being able to identify pregnant women and follow them through the course of their pregnancy. So this is just kind of the array of different digital interventions. Obviously, this would have to be sitting on the foundations of, having a strategy in place, legislations, a trained workforce, infrastructure. And the guidelines really just focused on those discrete functionalities or digital health interventions, and understanding, weighing out, okay, where have we seen good evidence to show that in support of them? Has there been any harms? What are some of the qualitative factors around their feasibility of implementation and acceptability, gender and equity considerations. And so I'll speak to the one that I think has become very, very popular in the era of the COVID-19 pandemic, which is client to provider telemedicine. And this was something that WHO recommended. This is back in 2019, but just that it complements rather than replaces face-to-face delivery of health services. So there was considerations from people within the health workforce that not everything needs to go to a virtual world, partly so that we don't forget about people that may not be able to have access to digital devices for being able to use the telemedicine services. And there may also be issues surrounding disability. So people that may have visual or hearing impairments may not be able to use these services the way that they would have been able to, with a physical type. As well as there were just a lot of considerations around patient safety, privacy, traceability. So if some type of interaction had happened, being able to trace and document what the health worker may have said, and being able to have that noted, and some accountability for who provided what service. And so really along the lines of considerations for protecting the clients as they're accessing these types of services. And some of the considerations that came out of this qualitative evidence as well that was supporting the formulation of the recommendation are things regarding the legal framework. So, if something, and in some cases we've seen cross-jurisdiction telemedicine in which someone may be in one country and seeking care from a service in another country. And so what would be the legal framework if anything was to go wrong, or being able to document that, any agreements that need to be in place. There is also a need to kind of clarify what could be done in remote consultations and what are things that still warrant face-to-face. Health workers at the time in our qualitative reviews had some concerns about liability. So if they weren't able to actually do a full physical exam and be able to really assess, with a face-to-face contact, what would be the drawbacks of providing telemedicine services in that context, and are there some things that you really should go in person? Again, this was not with the idea that there would be a complete pandemic across the world that would really inhibit this, but at the same time, it's still important that to understand what would require face-to-face contact, and what are some things that you can just continue to monitor and do through remote connections. And I think these are some of the continued learnings that we at WHO would like to learn about and understand a little bit better through all the experiences that are happening in the pandemic. What has really worked in the context of telemedicine, and what are some things in which you still need that human face-to-face contact, especially in the context of healthcare, where there may be some symptoms or there may be some things that a client may not know to notify the health worker, and maybe there could be poor signal, poor infrastructure, and that might limit the health worker's assessment of what to do next. I think in the context of family planning, it might be a little bit more direct and not need a full physical exam as, for other areas such as, even in sexual and reproductive health, such as antenatal care, where you may want to do a little bit more of a thorough investigation from a health worker standpoint. Understanding what regulations need to change. So for example, liability issues as mentioned, but also insurance schemes, reimbursement models. Now that services may be provided over telemedicine, how does this change the fee structure, are these things still that insurance could pay for, or whatever the payer mechanism is within that country. And then being able to document and trace past exchanges so that there is some level of accountability. There were also considerations around the workforce, really making sure that there's been adequate training and that the technology doesn't hinder or get in the way of the relationship between the client and the health worker, especially in low infrastructure settings where there might be a lot of disruptions in the actual connectivity. Being able to make sure that there's also an ability for health workers to be able to use their own skills, judgment within this changed context. So now that you're completely devoid of being able to see someone, there needs to be also health workers' ability to refine and be able to better use some of their own skills and judgment during this new environment. And just the emphasis on co-design, making sure that health workers are part of the design process in the planning and design and implementation, as well as just, setting up some regulations. Not all telemedicine services function this way, but there are some in which you can just contact your, ones that you can kind of contact your health worker. And in that case, being able to not contact them in hours that they don't want to be contacted, or how would this be managed? I think health workers were initially speaking to being overwhelmed. And these are all things that I think we could also relate to in the new, teleworking, work from home environment as well. There was also a recommendation that followed a similar parallel process on provider to provider telemedicine. In this case, this is not actually about clients, but health workers getting a second opinion from another resource and being able to have that from a more specialized health provider. There were other recommendations such as targeted client communication, being able to provide messages. It could be even interactive voice response or online services for people to access sexual, reproductive, maternal, newborn, child health issues, but just to make sure that there are ways to address sensitive content, particularly in with sexual reproductive health areas where there may be phone access, there may be different vulnerable groups that may be accessing this information, but they need to be able to control or be able to opt out of the way that they're receiving this content. I also just want to mention that within the context of the COVID, there has been digital platforms that have come out within the guidance for maintaining essential health services. So this is just one snippet from that document. And the last bit that I want to speak about is an operational component or an operational guidance component to the digital health guidelines, which we launched recently or in October 2020, which talks about how do you actually implement and plan digital activities in a way that they integrate with the National Health Program and that they're not just one-off time-bound limited initiatives, which I think is going to be something that's going to really be a challenge. And some of the next steps along these different initiatives that have come across, how do you sustain them and how do they actually be able to be part of a more cohesive national system? And so the DIG, the Digital Investment Implementation Guide, it fits along a multi-step process. There's a broad process to developing digital health implementations. You need to assess what's currently there, plan, define what you'd want it to look like, see if it needs to link to a broader architecture, meaning other implementations that are out there, define what the health content is that you would be using within this, and then the monitoring and evaluation, data use, continuous improvements, as well as the maintenance and scale up and sustainability. And so the Digital Implementation Investment Guide recognizes that there's a huge process. It really only focuses on 3 out of the 7 steps. But just to mention that there is a very their digital implementations have historically come about as a very ad hoc approach, but there is an interest to try to see how these can be a bit more systematic if possible, so that you actually have an organized framework of who are your actors, what are the priorities, what's the program context, what are the digital tools that you're using, what are the commonalities with other implementations so that you don't need to have, different telemedicine services popping up, like 10 different ones popping up, whereas maybe you can broaden out one so that it serves different populations or different health domains, and then budgeting that out, monitoring it, and trying to prepare a costed implementation plan that could be used for donors and further investments. And so I think I'm going to just leave this here to talk about with all the budding initiatives that we're going to hear about, and some that we may not hear about, but that are out there. We know that there's been a lot of activity, a lot of interest in the digital health arena. How can some of these implementations contribute to the guidance? So I wanted to put up some of the parameters in which WHO guidelines and guidances developed. There's domains around effectiveness. So if people can start in a rigorous way collecting information on the effectiveness, I know it's very difficult in the pandemic to be able to collect this type of information. There may not actually really be control groups. This is really a matter of necessity. And so, but if not, there could also be evidence that's collected on acceptability. So are people accepting this? What are their, what are some of the challenges that they're having? Feasibility issues. So what are some of the resources involved? What are the infrastructural requirements, the training requirements? And so these are all things that factor into the development of a recommendation. Also, just even understanding what the resource use is. Is this a very, cost-effective option? So what resources are required for implementing this? And then also implications on gender equity and rights. So how is this hindering, access? How is this promoting equity and rights? So information that can be collected through this, and I'm happy to discuss further, some of the rigorous methods in which these could be collected. But these different parameters, even if you're not collecting information on effectiveness, these different parameters certainly do contribute to the formulation of guidelines and recommendations. And so really encouraging people to document this as much as possible so that, with all the richness that's happening in terms of implementations, we can be able to harness these a little bit better for, for future learnings. So with that, I would just like to end here and, very eagerly awaiting to hear from others that have actually been implementing and putting these things on the ground, and look forward to the discussion. Thank you.
Great, thank you so much, Tigast. Really interesting presentation. We'll hear now from our panel from Rachel Misra at MSI to discuss MSI's experience using digital platforms. And Rachel's presentation is also pre-recorded, but due to an audio glitch, she'll also be joining us live just to round off her thoughts. So over to Rachel.
Hi everyone, I'm Rachel Misra, Senior Marketing Advisor in Digital Health for MSI Reproductive Choices. I'm going to talk through our digital response to barriers that emerged under COVID-19. So 4 key barriers. So first, the loss of usual face-to-face social networks. Secondly, some clients being unable to safely call us with adequate privacy at home. Third, movement restrictions, meaning that clients couldn't come to clinics. And then 4th, being afraid to come to a clinic due to the fear of catching COVID. So some of the actions and interventions that we put into place. So when face-to-face social networks reduced, we really increased our emphasis on building our online networks. So everything from our website, so making sure that content was up to date and we were answering FAQ content that was coming through across social media. We also did an urgent review of our website to see how it was performing, especially across low spec devices and lower bandwidth, which has kicked off a project to significantly strip down these websites. On social media, we created global content and it also did some urgent capacity strengthening on really building networks on social media rather than just using it as a tool for promotion. Across our websites, so we saw over an 100% increase in traffic globally to these sites from the beginning through to the end of the year, and it continues to grow, cementing the importance of our websites in their role of providing information but also facilitating referrals. Secondly, for clients that weren't able to safely call from the privacy of their home, we prepared for this because we saw early signs of an increase in social media messaging. So we upgraded to an enterprise chat platform to handle the surge in social media messaging. And we also created template responses to handle SRH FAQ. So these were template responses that the system could send out with videos, with images, and really help to kind of tackle some of the scale of messages that were coming through. We also actively promoted tools that we were seeing developed within the sector. For example, the World Health Organization COVID-19 chatbot, making sure that we were signposting and sharing these where possible, rather than thinking that we had to do it all and create it all. So not only due to the barrier, but also due to the promotion that we were doing online, we saw a significant surge in our social media messaging. So in Q1, before COVID really hit, for a lot of us, we had around 40K worth of messages a month last year. But then from Q2, 3 and 4, when the situation began to unfold globally, we reached an average of 85K worth of social media messages a month, so over double there. For clients that were unable to visit clinics due to movement restrictions, so where possible, we pivoted to remote service delivery. So across our UK and South Africa country programs, they were able to rapidly adapt to deliver medical abortion remotely. In other countries, this has been a slightly slower pivot, but we're seeing how we can use telemedicine creatively to deliver multiple different services, for example, across Ghana and India. Where telemedicine felt slightly more out of reach, we still did what we could to bridge the gap for clients that were at home. So, for example, in Uganda, we partnered with Safe Boda to be able to deliver family planning and emergency contraception products for our Marie Stopes ladies, who are providers that are based within the community. We also facilitated the delivery of SRH products from our in-clinic pharmacies where possible. Just to give some results from South Africa and their remote delivery of MA. So in the first month that they set up, so April 2020, they had around 84 consultations, but they've continued to grow the channel, and from last month, so Jan 2021, they had 741 consultations. So on the final point of clients being afraid to visit the clinic due to the fear of catching COVID. So again, our websites and social media were key in communicating status updates of whether clinics were open, but also what we were doing to protect the clients that were coming to clinic. And key to this was client spacing. And whereas in the past, appointment booking for us had seemed like more of a long-term ambition for many of our countries, this became an essential must-have to adequately space the volume of clients in our clinics. So we came up with, there was no time to implement a robust appointment booking system. So we came up with a kind of quick and dirty solution using Microsoft Outlook calendars and Excel spreadsheets, which we got up and running across 9 countries as a workaround to just facilitate client spacing during peak COVID-19 periods. So the progress we made in our digital interventions during COVID-19 have brought about some really positive results. And we're not just focusing on how to continue or scale these, but we're also trying to gain an understanding of how equitable these solutions are, especially for interventions like telemedicine.
Great. I'm just going to finish off the point because my recording cut out. I wanted to say, we have we won't be able to reach all audience segments. So, for example, with telemedicine in South Africa, we saw a limited reach with rural audiences due to the cost of delivery. But what we're starting to think about is more of a kind of planned exclusion approach where we properly investigate, okay, who does this solution not serve, and making sure that we put an equal amount of thought into the solution that will serve them instead. Great. Thanks a lot, everybody.
Thank you very much, Rachel. Really interesting. We'll now hear from Katira Abdi Wahad Ahmed from the Sudan Family Planning Association, which is an IPPF MA.
Good afternoon, everyone, and good morning and evening to our colleagues joining from other countries across the globe. Welcome. I am Dr. Katir Abdul Wahab Ahmed, Technical Lead at the Sudan Family Planning Association, the International Planned Parenthood Federation, IBPF member association in Sudan. It's my pleasure to join this session today to be able to share SFBA experience of establishing a call center as a response to the ongoing COVID-19 pandemic. The call center was established with support largely from the Women Integrated Sexual Health WISH program, funded by the FCDO. I will start with the Sudan context, COVID-19 situation, and very brief history of SFBA. Sudan is a country of great diversity in terms of topography, ethnicity, language, social norms, and living conditions. The country is composed of 18 states and 182 localities and a population of approximately 43 million. 70% of people live in rural areas. 80% are nomads, 2.2 million IDPs, and another 2 million refugees. Sudan has a youthful population with 20% of the population aged 10 to 19, and estimated 47% of the population live below the poverty line. Interestingly, an estimated 73.8% of the population own phones. In terms of reproductive health, maternal mortality rate in Sudan is one of the highest in the region. There is high unmet need for contraception by about 26.6% and low CBR by 12.2%. Sudan is a country that is undergoing transformative change in recent years. The conflict, the chronic poverty, the underdevelopment, and the economic sanction. All of these factors make Sudan a special case when we are talking about COVID-19. Regarding the COVID-19 situation, to date, Sudan has reported around 29,933 cases and 1,849 deaths. However, these figures are thought to be underrepresenting the actual scale of the pandemic in the country due to several factors, including a lack of testing provision. Sudan health system was already weak and deteriorating, which impacts the availability and accessibility of SRH services. SFBA has been providing SRH services to communities in Sudan since 1965. SFBA is present in 13 of the 18 states of Sudan and are working on plans to expand to other states in the near future. Through our networks and approaches, we have been able to reach a huge proportion of the Sudanese population with SRH services. As part of the lockdown measure, SFBA was not able to provide SRH services through its usual channels, and as a response, SFBA established its call center. The overall goals of the call center was to minimize the impact of the pandemic on SRH service provision. The specific objectives of the call center were to enable continued access and utilization of SRH services during the pandemic, and to ensure that vulnerable group of people who might not be able to access the static health facilities, including people living with HIV, people in remote areas, displaced refugees and nomads, are able to get services. And also to respond to emergencies that may occur by offering counseling and referral services, and also to respond to SDPV cases by providing counseling, timely referral, and psychological support, and also to continue to meet the goals of the program, particularly our key target population, adolescent, youth, and those living in poverty. Regarding the establishment of the call center, I will talk about the plan, training, and launch. In terms of planning, we developed a strategic partnership with Ministry of Health, the Sudanese Society of Obstetrics and Gynecology, and other NGOs like Red Crescent to work with us in the state where we do not have static facilities. We also map which clinics are were still open during the pandemic, which was important for making referrals. We set up with 3 obstetric gynecology consultants and 1 family physician to take the calls, and we later expand them to 10 obstetric and gynecology consultant and 4 family physician. they were expert, but we provided them with refresher training and training on what we call the call center packet, which included call center technology, effective communication with client on the phone, and psychological first aid. We had a one unified free call to all the country, and we worked to promote the call center through SMS, radio, and social media. We work closely with the largest telecommunication companies in Sudan on SMS plus to client, which drove traffic to the call center. SFBA long-standing work with the community leader was also important. For example, in Kassala State, a community leader was reported to have lent his mobile phone to members of the community who did not have their own mobile phone. And he was translating and discussing our services, counseling, and medical recommendation to those who are not speaking the Arabic language. We adapted our routine client register to the call center, and we have an application for data entry and recording. From the beginning, we put in place safeguarding measure. For example, we had a beneficiary feedback mechanism as part of the IVR system, where clients were able to report on their experience of using the call center. M&E was very important to us to understand the impact of this digital health intervention. We had system reporting where we capture calls, service provision, and referral. Also, reports by day, age, and call recording to enable improvement to service delivery. So in terms of how the call center works, our family planning method, and we also make referral to the Ministry of Health clinic. And we also establish a WhatsApp SMS system where a client can write in question and send lab results. Regarding the data from the call center, the total number of calls that we received between April and November was 89,450 received counseling and awareness through the IVR, and 9,900 clients received direct services from the call center provider, and those we offer them counseling, consultation, and referral. Sometimes we provide investigation and treatment according to client situation. Majority of the callers calling in were female at 71% and 29 were male, and majority were over 25 years. However, 18% were below the 18 years of age. The most requested services were contraceptive, infertility, and antenatal care. Regarding the overall experience, we think that the call center has a positive response from communities, partners, and providers. And we have the unique picture of the call center. On it, we have men talking about their sexual problem. Men are engaging more in reproductive health issues because traditionally in Sudan, SRH was seen as a woman issue, but through the call center, we have seen increased male engagement. And also women talking about their loss of libido. Usually libido is not an issue. Women talking about it due to the country culture and customs. But the privacy in the call center made women more comfortable to talk. And we have young girls asking without barriers about their reproductive rights, and people living with HIV asking without stigma. And women with long-standing symptoms with financial barrier are now contacting us. Traditionally, majority of women who are experiencing contraceptive side effects more likely to switch or to continue using family planning. But in the call center, women are more likely to be open about their contraceptive side effects. SMS is a popular method of promoting traffic to the call center, and working with the telecommunication was very important. Our plan to sustain and expand that we are sustaining the call center, bringing in-house in partnership with the stakeholder to continue provide the call center services even beyond the COVID-19 pandemic. And we will continue to promote the call center and looking out how to reach hard to reach population and sharing our experience with others. And also we will develop a mobile application. The call center is a successful story of SFBA, but challenges do exist in terms of supply chain disruption and high cost of intelligent distribution, lack of PPE, and staff availability. That brings me to the end of the presentation, which I hope participants found useful. I would like to thank the organizer for the opportunity to share our experience and would be happy to take any question in the Q&A session. Thank you.
Thank you so much. And I am seeing a number of really good questions coming up in the chat, so please do keep them coming. For our last panelist, I'll hand over to Millie Kagwa at PSI to hear about PSI's varied experiences with digital technology.
Thank you. Hello, everyone. My name is Dr. Millie Kagwa, and I'm the Senior Clinical Advisor, SRH at PSI. Today, we're going to explore a few examples of digital adaptations across PSI programs. And these were developed to safely continue meeting our clients' FP needs during the FP pandemic. Next slide, please. So today, our presentation will cover 4 main parts. We would like to take a moment to explain the background of the COVID-19 monitoring of FP programs, and then we'll take a look at the digital adaptations across 2 different FP program streams. We'll look at equity, and then we'll look at the private sector. For digital adaptations that promote FP equity, we shall take a look at the example of Adolescent A360 program in Nigeria and the delivering equitable and sustainable increase in family planning, also known as DESIP program in Kenya. And then for private sector, we will look at the digital adaptations implemented by the social enterprise program in India. Lastly, we'll talk a little bit more about looking beyond COVID-19 and the continuation of digital adaptations into PSI's routine FP programming. Next slide, please. For a little bit about background, move to the next slide, please. Results for scalable solutions, RR4S, supported the COVID-19 adaptations monitoring of the selected PSI FP programs. While RR4S supported the monitoring of activities, a range of donors funded these activities, and these were implemented by PSI country programs. Monitoring occurred from May to November 2020, with each PSI program compiling data in a standard process documentation, noting the COVID-19 challenges on an Excel template. Next slide, please. So let's take a look at reaching youth with family planning messaging in Nigeria through the A360 program. And this will be presented by Joy Otasanye Ede, the social behavior change specialist and digital communications lead at Society for Family Health. Next slide.
My name is Joy Ede. I work on the A360 Amplify project. I manage the communications and the digital solutions. So this morning, I'm here to talk about how we reach the youth in Nigeria through the A360 project. A360 ran from 2016 to 2020, and we targeted the youth through FP demand creation and service delivery as well. So for the demand creation, we use the life, love, and health skills class, and we target unmarried adolescent girls. And for service delivery, we provide free FP methods through public facilities that A360 project partnered with. And the structure we use is the hub and spoke model. So when COVID-19 hit, the major challenge that we had was a restriction in movement, the lockdown. And with the restriction in movement, there was interruption in access to information and also access to services as well. And so that automatically lowered demand for FP services among the youth in Nigeria. And we looked for the opportunities to capitalize on. We looked for how to adapt to keep serving the youth in Nigeria. The first we looked at was the Facebook page, where we were able to launch a campaign to reach the youth with information on FP and information on COVID-19 as well. And the life, love, and health skills class, which normally used to be in person, we had to digitize that as well So we moved that to WhatsApp, where we created WhatsApp groups for the youth to join and learn and get information on FP and also on COVID-19 as well. So for the Facebook campaign, with the promotion, we broadened our reach. So the online community was expanded. We're able to reach more young persons with FP information and information on COVID-19 as well. And we're able to link the youth who were interested in accessing services. We're able to link them to the facility or link them with the provider, who also added them to the WhatsApp group for deeper engagement. So looking at the WhatsApp group, it was a platform for them to get information on FP, get information on skills for life, information on skills for love and relationship, and also skills for their health. And we saw that it increased the exposure that youth had, to information, and we also saw an increase, in exposure to the project and the intervention as well. So those are the adaptations that we carried out during the COVID-19. Thank you.
Thank you, Joy. Thank you, Joy. Let's now take a look at exploring how the DESIP project has been maintaining FP access for youth, rural women, and women living with disabilities in Kenya. And this will be presented by Bill Okaka, the Senior Manager Technical Learning at PSI. Next slide.
Hi, everybody. My name is Bill Okaka. I'm the Learning Manager at DESIP. DESIP is funded by the Department of International Development. And for this adaptation, we are looking at how we manage to maintain family planning access for women living with disabilities in Kenya. DESIP has had a lot of learning through COVID-19 period. Since 2019, DESIP has continued to target young people, rural women, and women living with disabilities. That has been through adaptive service delivery models and training health workforce in disability inclusion. So through the implementation, DESIP has had challenges, and that has been brought about by two things. One is social distancing, another one is lower demand for family planning services. So I would like to explain that. Social distancing was government approach to reducing the spread of COVID-19 in the country. It affected DESIP's approach to delivering family planning information and services. So DESIP moved away from activities like community-based dialogue sessions to virtual outreaches. When we talk about community-based dialogue sessions, we mean a setting under a tree in a classroom or a place where the crowding effect will happen, and there will not be a way of doing a 1.5 at least distance between one and the other person. And of course, the communities deep interior also had delayed access to personal protecting equipment, and that is like masks. So we moved away from such settings to virtual outreaches. Subsequently, the social distancing led to lowered demand for family planning services because women of reproductive age feared contracting COVID-19 at the health facilities. Equally, women of reproductive age also kept away from the health facilities due to government's circular, which indicated family planning services as non-essential, especially in the first few months after we had confirmed COVID-19 case in the country. So COVID gave DESIP an opportunity to look out for those digital adaptations that we did. So there was virtual training in disability inclusion for providers and community health workers. And we also did youth mobilization via social media. Here, social media, we mean WhatsApp and Facebook, which is largely used in this part of the world, and of course, also largely used by young people in the counties that we reach. So virtual training in disability, family planning inclusion is important for DESIP programming, and that helps it reach its target audience or goals, or the people who are actually living with disability who are in need of family planning. Through sub-county and county staff, DESIP was able to roll out a virtual disability inclusion training via Zoom, and this was great because it reached 225 ultimately through a cascade process. And the training actually focuses on social inclusion model and its application to DESIP program context and the county health systems. The training also looks at key concepts relevant to social inclusion and oppression, including stereotyping, discrimination, sexism, racism, exclusion. And it also focuses on systemic nature of inequality and exclusion in personal and institutional processes, and the need to challenge those status quo. And therefore, since the virtual training, several providers have been able to take effort to undertake many changes that have happened that are in the facilities. We are talking about having disability-friendly toilets and having ramps and wheelchairs that are very, very important in the process. So in terms of youth mobilization via social media, basically WhatsApp and Facebook, we were very, very keen to ensure that we reach as many as we can. And where there was no connectivity, when I say no connectivity, I mean there could be problems with electricity, or there could be fluctuation of the connectivity in terms of the network itself. And so we were very keen to ensure that we continue to reach young people even through the SMS platform, which is very, very good in terms of network and spread in the country. So to link young people to DESIP's supported health facilities. So between May and November of the year 2020, we were able to reach over 15,000 adolescents with family planning information. Thank you.
Thank you, Bill. Lastly, let's hear about the private sector engagement through social enterprise in India. This will be presented by Vidhi Kari, Assistant Manager, Digital Marketing, Social Enterprise India Project. Next slide, please.
I am Vidhi from PSI IPL, and I will be telling you all about our digital initiatives in India that we started in mid-2020 and got accelerated because of COVID setting in. Now, some of the primary reasons for this acceleration in our digital journey were the countrywide movement restrictions, not to forget the fear of going out during these times. Due to the same, no or limited access to family planning products and services. Before I talk about the journey we set into, I would like to briefly tell you about our digital platform Between Us, a website which is a central asset to connect with our audience along with active social media handles on Instagram and Facebook. Between Us is a place for women and girls to learn about menstrual, sexual, and reproductive health. They are provided with guidance in a private and personalized manner, and it also facilitates access to high-quality products and healthcare services. Above all, the platform also provides support on subscription during the entire journey cycle, that is from pre-purchase to adoption and post-use. The target audience for these digital initiatives are women and girls of 18 to 34 years of age, from SEC A3 to C1, from metros and T1 towns of 4 states, UP, Rajasthan, Delhi, and Orissa. Our digital consumer journey cycle starts with self-care and information, where we ensure that the TA is exposed to communication on social media and other online channels that persuades them to seek more information on the topic. This leads them to an AI chatbot or a cyber educator or the website which has articles and FAQs. The next stage is providing access to e-counseling and online access to products. Individuals who engage on AI chatbot or with the cyber educator and show an intention to behave, they are then referred to an online video counseling platform so that this individual can receive e-consultation along with procuring an e-prescription from the doctor, which would then be uploaded at the time of purchase from an e-pharmacy. Apart from this, we have select outlets which keep our portfolio products on our website and a network of providers for services if someone shows interest in the long-term method. Talking about the impact of our campaigns, in a month, on an average, we run 15 different ads on 1 or 2 chosen themes. We reached a unique audience of over 1.2 million individuals, which roughly constitutes to 10% of the universe of the total audience in these focus geographies, out of which an average of over 40,000 individuals engage with us monthly through these digital campaigns. Digital campaigns has brought continuous growth in engagement on these online platforms. New partnerships with e-pharmacies have been set in place to reduce the number of touchpoints in the journey. That is, to provide consultation and purchase at one place. There is evidence of growing popularity of personalized conversations, and we are working on having such conversations that can also answer top-of-the-mind queries. With encouraging results, we are continuing to refine our journey cycle in order to increase the uptake of various contraceptive methods. The rise in digital access, especially during COVID-19, has helped us leverage this medium and reach our target audience to help them adopt contraceptive methods successfully. Thank you.
Thank you, Vidi. Let's take a moment to discuss the continuation of digital FP adaptations. Next slide. So while COVID-19 is still impacting FP programming, and as the pandemic evolves, PSI programs still intend to continue utilizing the recently adapted digital tools, especially for demand generation. So with A360, we're going to see a continuation of the use in the WhatsApp digital life, love, and health classes with the in-person elements included as well. And then with DESIP, we're also going to continue youth mobilization using WhatsApp and Facebook. The social enterprise program in India will continue to improve on their chatbot and partnerships with e-pharmacy. And then we're still going to continue supporting providers, pharmacies, and community health workers through the new e-learning platforms, which we've seen very successful. And with the DESIP program, they're going to continue virtual training with WhatsApp follow-up for areas that have weaker internet connection. And then adding to the evidence of what's working and what's not working in adaptations, PSI is looking for further opportunities to be able to measure the impact of these digital adaptations beyond just the qualitative descriptions and key performance indicators. Next slide, please. Yes, I would like to say heartfelt thank you to the A360, DESIP, and the Social Enterprise India program teams for their enthusiasm and their effort to document and share COVID-19 program adaptations. We've come to the end. Thank you very much.
Thank you so much to all our panelists for those thought-provoking presentations. It's been really fascinating to hear all the different ways that organizations are pivoting their digital solutions in this time of COVID and what the learnings are for the future. And thanks to everyone who's submitted questions. Please do feel free to keep more questions coming, and this will be great fodder for the upcoming discussion. So to lead the discussion, I'll now hand over to my colleague Trinity Zan, who is the IBP Task Team co-lead and Associate Director of Resource Utilization at FHI 360. So Trinity, over to you.
Thanks, Megan, and thanks to all of our wonderful panelists. We're so happy that they were able to pre-record and minimize technological challenges. Of course, we always still have some, but they're also with us today. So they're available now for our discussion section. But before we move into that, we just wanted to ask a few more polling questions to get at the rich knowledge base among all of you participants. So you'll see them on the screen, and we'll just ask you to respond to those as the poll pops up. The first is, what have been the biggest challenges to using digital technology during COVID-19? And you may pick all that apply. And you'll need to scroll down on your poll. Instead of these coming up individually, they're all in one box. So you can scroll down to see the other questions. The second question is, which categories of digital adaptations do you think will continue post-pandemic? So we heard some of our speakers talking about which they feel they will continue to use. We'd love to hear from you. And our last question is, for those implementing digital adaptations, are you or will you be collecting data to determine any of these aspects, effectiveness, cost, reach, something else. And this also relates to some of the issues that we hope to touch on in the discussion. So this is great. I see lots of people responding related to challenges. Of course, low or limited bandwidth is coming out on top, and also the time that it requires to train people on how to use these technologies is not insignificant in some cases. Looking to what may continue, I'm seeing a lot of positive thinking and enthusiasm for the information directly to clients, but also for scheduling appointments and reminders and telemedicine. And so again, today we heard quite a bit about telemedicine and the direct information to clients. And then for the last, what kind of data might you be collecting? It looks like a lot of people are collecting effectiveness data, which is really exciting. And I would love if you have plans to do that, if you would put into the chat, and perhaps we can hear from one or more of you, but also cost and reach. And this is critical for the evidence base around which we're still really growing information, particularly related to cost and reach. So thank you, everybody. We can take down the poll, and I'm going to first go to some of the questions that have been coming through the chat. And after we do that, or while we're doing that, if you have a question that you'd like to pose directly to a speaker, you can go ahead and use the raise your hand function, and I will try to take a look at that. There are so many questions coming through. We certainly won't have time to do all of these, but I did want to ask one question that I thought was very interesting. This came from Christine Rowe, wondering, oh, first let me ask our speakers if they're able to go ahead and turn on their cameras, and they'll be ready to join us. From Christine, has it been possible to facilitate more consultations or service delivery across borders with the use of these digital technologies? And might that lead to sidestepping some restrictive policies in some contexts? So I wonder if any of our PSI or WISH related presenters would like to respond to that question, if you've seen the use of these technologies across borders. And feel free to just unmute yourself as a panelist to respond to that question. Or if the answer perhaps is no. Okay. Well, there you go, Christine. It sounds perhaps that has not yet been encountered, but that's a really, really interesting question. I'd also like to ask a question that was raised by Priya Emart, wondering for both MSI and PSI and IPPF affiliates, how is the data that you are about your remote consultations and the services that you're providing through these digital technologies, how is that being incorporated into routine HMIS systems like DHIS2? And are you experiencing any challenges in integrating that data about these remote or telehealth consultations and services? So anyone from PSI, if you'd like to respond, or perhaps Rachel, I could ask if you could come in first. Or Millie, go ahead, please.
Yes. That's a very interesting question. And I think that's one of the things that is a big challenge for many digital interventions. Again, for the COVID-19, many of the data that we're collecting really is distribution data, so product distributed. So that's a little bit easier to find its way back into the HMIS rather than just through how many we've distributed to the end user. But when it comes to people reached and information like that, that's a little bit harder based on whichever program that you have. So I would say, again, it's not easy. It's easier where you're dealing with services, because eventually you have either a product distributed, or actually it eventually gets down to the health provider or to a community health worker who has access to the HMIS forms for the ministries of health that we're working in. Then the last, I just wanted to give an answer to the question, the first question that was asked about, have we seen these digital interventions across borders? I think it is very possible for the reach to go beyond, especially for instance in Facebook, but we've not necessarily been tracking those particular, the reach outside the intended people that we intended to reach with it. So I think that's an interesting question that would be very good to look at to see how far are these messages reaching. Thank you.
Thanks, Millie. Rachel, did you want to add anything?
I didn't have anything to add on that question specifically, but I was wondering if I could just touch on one of the other questions that I saw pop up in the chat that was really interesting. So it was just around kind of our safeguarding around and telemedicine and how we deal with any kind of incidences that might come up. So our telemedicine guidance for providers, the flow kind of matches what we do in person in terms of making sure that a client fully understands what physical symptoms they should expect, especially with things like MA. What changes when it's remote is really that from a safeguarding perspective, we need to ensure the client's alone during the telemedicine consultation. And if we're unsure about that at any point, we'll ask the client to come in for an in-person service. If we fear that there are any signs of coercion. And then in the package that we provide, obviously, to kind of to again ensure the client is monitoring their own symptoms, we have a clear checklist of what to expect, what's normal, what's not normal. And here's really where our contact centre play a pivotal role in, we make sure that their number is promoted at all stages throughout the telemedicine process. And we've got a comprehensive adverse event and medical emergency management guidance for all of our contact centres. So they've got triaging job aids and an escalation process. And the question also asked about GBV. We're currently building networks so that we're able to refer out from a GBV perspective. Because we're not yet kind of fully fledged in terms of providing these services directly. So we're kind of leveraging on partnerships with that.
Thanks, Rachel. I see a very interesting question from your title on the chat box is Musa. So I would love if you would please unmute yourself, Musa, and ask your question if you're comfortable and able to do so. Okay, we may not be able to, but I thought it was a very interesting question. And so this would be for any of our panelists. The question was, maybe one of these unintended consequences, or perhaps it could have been anticipated, is, for example, in the call center, both the engagement of men, but also being able to pose questions that might have previously been taboo, whether it's about libido or menstruation or youth sexuality. And the question was, specifically in that instance, does the team have any plans to find ways to make women more comfortable to bring up those issues, women or men, in face-to-face visits? And I wonder if any of our panelists have been thinking about that question, about how to translate perhaps some of the lessons learned and the opportunities gained from digital interventions back to our non-digital times, if and when we return to those. So I'm not sure if Dr. Katira is on the line, if she's with us. It'd be great for her to respond, but anyone else who has thoughts on how to take those benefits and translate them into ongoing service context would be great.
So I'm happy to speak to one thing that we're doing. So what we've recently embarked on at the moment is commissioning content about a kind of broader array of topics rather than just kind of focusing on the kind of core services that we offer. We're also exploring things like, everything from like vaginal discharge to like when is it normal to stop using condoms with a sexual partner, and kind of some of these more fringe questions that we get that might not necessarily come up in a consultation you know, when it's purely about like, this is the method of contraception that I need, but kind of some of these questions that we see on social media and we see come in through our contact center. So what we're doing is we're working with a content partner to get this content commissioned, get it created, and then put it on our website and promote it through social media, so that we're really encouraging these conversations about, you know, the full arena rather than just kind of pure service delivery. And the hope is that then we'll be able to kind of bring that more into the conversation that we have at the service point and empower our clients to have these conversations and make them realize it's okay to talk about these more embarrassing or taboo topics around SRH.
That's great. Would any of the speakers from PSI like to respond to that question?
Hi, Vidya from India.
Yes, please.
Yeah, so, you know, we are definitely trying through digital conversations to make the more embarrassing topics, to discuss those topics, to make people comfortable with them, with the help of humor. We think that could be one route. Also, when we have one-to-one conversations with a cyber educator, and if people are uncomfortable, they do ask us questions that, you know, will we be judged, or, you know, things like that. So we try and make them comfortable. We tell them that, you know, they can go ahead and ask the doctors that they will be consulting. There will be no issue, you know, at their end. So yeah, so we're trying to make them comfortable. Right now, it's in the digital route itself, but, you know, we hope that, you know, even in the offline set, people do get comfortable having such conversations. Yeah, thank
Great.
you.
Thank you. I'm wondering, there's a few questions that have been, of course, about privacy and confidentiality, and how we can ensure that during use of these digital platforms. And in particular, a question from Martha Brady, about how we can balance the need for privacy and data protection with the desire and the ability to follow and support clients long term, so it's not just, you know, a one-off kind of acute need at the moment. Again, I wonder if any of our panelists could speak to how you're able to capture information perhaps about clients who are coming in for telemedicine or e-counseling, or even on the call-in centers. Do you retain that information so that you can follow up with them and support them over time, or do data and privacy concerns prohibit that?
So one thing I can speak to for MSI is some of the questions that we'll check if a client calls through our contact center. So, you know, we do find there is huge value in being able to follow up with clients, but, you know, we'll always ensure that that we check, you know, who owns the phone, what times are okay to call them. And, you know, even on our websites, if a client does fill out a form, we'll check things like, you know, is it safe to call you? Would you prefer SMS? Would you prefer WhatsApp? So I think it's the balance of, you know, it can be very advantageous to capture data that enables that continuum of care and you know, follow up, but also ensuring that we're doing it in a way that's best for the client. So, you know, ensuring that we're gathering those preferences. We make sure that, you know, we clarify questions around phone ownership.
Yeah, that's great. Vidhi, would you? Oh, go ahead,
I'd like
Millie.
to say something. Yeah, at PSI, we understand that especially when you're dealing with the digital platforms, it's really hard to deal with privacy. And right from the start, we came up with a framework, a quality of care framework that provides standards and guidelines for country platforms to use as a guidance, as a measure on dealing with client communication using digital applications. So the countries have this, and they're able to take a look to see, are they able to answer the question on informed choice? Are they really able to answer the question on privacy? Are they able to try at least to give the client some kind of continuity of care using referral systems and mechanisms in their digital tools? So before any digital tool is actually set out, we have a team that takes a look at it and evaluates. We have a quality of care team that will look at that will evaluate this digital campaign, the digital, the messages, and even the how we're giving it out. Is it meeting the standards that we've put? Are these indicators, we've put in place indicators that we look at to be able to see that this tool is really actually meeting the needs, meeting our standards of care and practice domains.
Thank you, Millie. Vidi, would you have anything to add to that? Okay. I wanted to ask a question. I think some of the comments coming through the chat relate to this. I'm curious to hear from our speakers whether the data that you're collecting and the experiences that you're perhaps documenting or just going through, whether you are communicating that to your various government counterparts for the purposes of informing policies. And so we started off the presentation with information from WHO about what their guidelines recommend in terms of digital technologies and where there is still a need for evidence. And so I'm just curious, could each of you speak to whether and how you're communicating about use of these new and innovative digital technologies and the effects that you're seeing and the outcomes that you're seeing with your government counterparts, such that they might make different or new decisions related to policies and guidelines for the use of these digital technologies outside of the pandemic setting. Millie, would you want to start us off? You're on mute, Millie.
Thank you, Trinity. I'd like to give a chance to Vidi, Joy, and Bill, who are also on the line, to respond based on the country projects that we've responded to. Before maybe I talk about the broader PSI picture. Vidi, Joy, Bill, do you want to add something?
Thank you, everybody. At PSI and for DESIP program, particularly in Kenya, and I hope I'm audible enough, it was good for us to be able to join the process in terms of adaptive learning. And one of the things we're doing at DESIP is to go through what we call the learning agenda. And we have set one of the learning agenda for the organization is to look at how effectively we can mobilize young people for SRH. And of course, this came in line when we were doing the adaptive learning processes for COVID-19. And of course, now what happens is that the information we get from the regions we have, or the sub-counties we work in and the countries we work in, is actually systematically shared and actually almost on a monthly basis with what we call the technical working groups for each particular county. For DESIP, we are very keen to work with the RAMCA, or what we call reproductive maternal health, child health, adolescent health, TWG, which actually sits in to get the information that we receive on the ground. And of course, we share with them, and they use this to be able to change the directions of how they are faring on and what they're doing. One of the interesting things we got from the ground was the evolution of youth mobilization that actually changed during the COVID-19 time. And we had to inform Ministry of Health on approaches of how to meet young people, right from doing community participations and in terms of mobilizing people in the field and doing the public shows and sports activity. Young people actually moved to digital platforms, and we actually informed the Ministry of Health that we are now getting more young people on digital platforms. And that made counties, like one of the counties in Kenya, Migori County, now invested in engaging with radio. And therefore, now they began reaching and talking to young people through radio. And interesting enough, because of our engagement with that particular county, they actually also started what we call a toll-free phone number for young people to call. And they set up a kind of, quote unquote, like a call center for if 7 people were able to receive calls from young people. And on average, they are doing like 30 calls a day. That's what is happening now. And much of it is about contraception, menstrual issues, male sexuality issues, and that kind of thing, and they're able to respond to. So this was good for us because we managed to get one of our counties to go the direction and follow young people where they are. Then later on, we also realized that young people are actually forming groups where they are able to do something like table banking because now they are together and they're trying to do it digitally. In Kenya, we have a way of sharing money, of forwarding money or receiving money through the mobile transfer, which we call M-Pesa. And therefore, young people are more getting connected through the system. So we are also trying to reach them through the groups that they are formed to be able to collect money together to do their things. So hopefully, yes, this has really been of help to DESIP. Thank you so much.
Thanks, Bill. I think that's a great example. And the A360 program is another one that is already working at integrating almost all their systems and the project implementation into the national government system. So everything that they work with, or the digital tools and the innovation that they come up with are done in conjunction with the government, with the Ministry of Health. Joy probably wasn't able to share much there, but at least I know that they are integrating the whole program project, and that includes the digital innovations and adaptations into the Ministry of Health systems.
Yes, thank you very much, Millie. Hello, everyone. Okay, so just to build on what Millie has said, we're working with the state government where implementation is happening. So we're adopting like a bottom-top approach, not like at the federal level, but with individual states to integrate the program, the A360 program, which includes the digital solutions and the service delivery and the demand creation component. And so what we are doing with the government is to outline everything that we're doing, and there now see what is already running in the government that they can easily integrate, our solutions into. And what we have been getting positive responses, at least from about 5 states that we've been to now. They have identified the components of the programs, including the digital solutions that they are ready to integrate, into their systems. The only issue that we are still working around is around phone ownership, especially in the rural communities, phone ownership and then access to internet. So that is where the challenge is, especially for young persons in the rural. But for the urban, settings, that will easily fly. Thank you.
Thank you. Rachel, did you want to contribute to that question?
Yeah, sure. So this is about us working alongside governments, right? So the first example that I would give, so in our UK program, during COVID, due to movement restrictions, we worked with the government to temporarily lift the legislation that says that both medical abortion pills can't be taken at home. So that really enabled the delivery of telemedicine so that both pills could be taken in the client's home. And we're now working really closely with government. We're able to show the kind of positive results from a medical outcome perspective, like the safety, the efficacy, also kind of from a client experience perspective, that kind of, the demand and the positive experience that we're getting through feedback. So we're providing all of that information to work with the government and to kind of influence to make sure that this change can become a permanent one rather than something that's put back into restriction after COVID. So that's one way that we're working really closely with government. And then from a country program perspective, so some of our countries across Africa and Asia, a lot of our digital health counterparts sit on, MIS working groups with governments and ministries of health. So, we regularly provide guidance and support to help improve data quality more broadly. And, our COVID-19 experiences will continue to improve this collaboration.
Thanks, Rachel. Those are great examples, as well as those from our PSI colleagues. So I'm noting that we're at time. I'd like to thank all of our presenters today and our participants for all of your wonderful questions. I think it was a very active chat. And I would just like to encourage everyone here on that last note about both translating the evidence and the experiences that we're having into policies and programs. So as much as we can speak to our government counterparts, but also in response again to Tigist's first kind of call to create more evidence, there are lots of places that you can, and we would love for you to share your experiences and your data. You can upload things into the WHO Digital Health Atlas. If you are connected to the High Impact Practices and Family Planning Initiative, there are usually open calls for new evidence and data related to digital health. So we would encourage you to please share that there. Share it through the IBP network. I really personally feel like we want to seize on this opportunity of so much pivoting toward digital to not lose the actual concrete data and experiences. We have to have that, or in 2 years from now, we're all going to say that was nice and lovely, but the people who may not have experienced it may not believe us. So let's please do everything we can to document, to measure, and then to communicate that out. So on that note, thank you to everybody, and I hope you have a wonderful rest of your days and nights. So thank you.
Thank you.
Bye, everyone.
Thank you.
Thank you, everyone.